Hello and welcome to tonight's Immunization Coalition webinar on pertussis. A warm welcome to everybody. My name is Andrew Minton. I work for the Immunization Coalition and I am the Education Manager. I would like to acknowledge the traditional custodians of the various lands of which we work and welcome any and all Aboriginal peoples and Torres Strait Islander peoples that may be on this webinar tonight. I would like to pay my respects, and on behalf of the Immunization Coalition as well, we would like to pay our respects to elders past, present and future, and specifically the Gadigal people in the Sydney area of which I reside. I would also like to celebrate the diversity of Aboriginal peoples and their ongoing cultures and various connections to the animals, the lands, and the waters of Australia. Just a bit of housekeeping. The presenter tonight, Dr. Andrew Beard, will present for about 40-45 minutes, which leaves us about 10 to 15 minutes for questions. Please submit your questions in the Q&A box or function down the bottom of your screen. You can use the chat function as well, and I encourage you to do so. And anyone wants to comment within the chat to respond to other people's comments, please do so. If I'm not able to get to your questions tonight, or we run out of time, or we haven't fulfilled the question in its entirety, then we will be sending out the questions as a Q&A document to all of those that register, just to make sure that we do answer all the questions thoroughly. These will be sent out next week. This is a recorded session, so everybody will be on mute, and this entire presentation will be available on our website by approximately next Wednesday. And to respect everybody's time, we will finish promptly at 7 p.m. tonight. So if I could just have the first slide, please, or the second one. I'd just like to introduce our speaker tonight. So I'd just like to introduce Dr. Andrew Beard. Andrew is a general practitioner in St Kilda, Melbourne, and is a medical advisor with a medical defence organisation. He is an Immunisation Coalition member and is an active member of our Scientific Advisory Committee. He has a background in rural general practice and medical education. And with that, I would now like to hand over to Andrew to take us through his presentation on pertussis.
Thank you very much for the introduction, Andrew, and welcome everyone to this evening's session. We're going to be looking at pertussis and the prevention of pertussis and providing an update in respect of its management. So to look at the objectives. So over the next hour or so, we're going to be looking at the epidemiology of pertussis. We'll be looking at vaccine effectiveness, vaccine coverage rates, the National Immunization Programme schedule recommendations, and with a particular emphasis on the benefits of pertussis vaccination in older people. So this is to introduce the star of the show. This is Bordetella pertussis. Bordetella pertussis is a gram-negative aerobic encapsulated coxobacillus, first recognized well over 100 years ago. And it was recognized by this gentleman. This is Jules Bordet, a Belgian immunologist and microbiologist. It was in 1906 that he and Octave Agenjou isolated Bordetella pertussis in its pure culture and proposed it as the cause of what was described as whooping cough. In 1919, Jules Bordet was awarded the Nobel Prize for Medicine and Physiology for his work in immunology. He died at the age of 90 in 1961. And just a little bit of trivia, the Bordeaux railway station in Brussels is named after him. So to set the scene, it would be helpful to review the clinical course of pertussis illness. The incubation period is wide-ranging from a week to 3 weeks, but typically 7 to 10 days. Cases are infectious from the onset of the catarrhal symptoms. That's the snuffles, runny nose, snot, and low-grade fever. Occasionally a mild cough can accompany the catarrhal phase of the illness, which can last for between 1 and 2 weeks. The classical paroxysmal stage then follows, and that is characterized by 3 things. The paroxysms of rapid cough due to difficulty expelling thick mucus from the tracheobronchial tree. These can occur as often as 15 attacks in every 24 hours. Tend to be more frequent and severe in the first 1 or 2 weeks of the illness and then gradually diminish. So the cough is the first feature. The second feature is the whoop, and that's an inspiratory whoop. After the prolonged expiration of cough, there's a whoop of breathing in. And the third feature is vomiting, which typically occurs after a paroxysm or bout of coughing. So the typical paroxysm is the cough, the whoop, and the vomiting. Communicability typically decreases and is really negligible 3 weeks after the onset of cough, but it's highly communicable, and secondary attack rates of about 80%. So about 8 out of 10 susceptible household contacts will get infected with Bordetella pertussis. So that's the enemy. That's what we're dealing with. And this is to summarize the incubation period between 1 and 3 weeks. Important for us as clinicians to know the childcare and school exclusion. So it's 21 days from the onset of cough, or 5 days after antibiotics have been started. If there are unimmunized contacts under the age of 7 who've been in the same room as the case, then those individuals should be excluded for 2 weeks from the last exposure. But it's virtually not communicable from 3 weeks after cough onset or 5 days after antibiotics have been commenced. What about antibiotic treatment? Yes, there is a role for antibiotic. It eliminates Bordetella from the nasopharynx, minimizes transmission. So it's about protecting others as much as it is protecting the individual who has the infection. It's recommended to have antibiotics if diagnosed less than 3 weeks after the onset of cough, but not recommended if the diagnosis is made thereafter. So the idea would be to avoid contact with others, particularly susceptible others, for 5 days after starting antibiotics. Prophylaxis, that's giving it to people who are at risk. Complex area, certainly infants, pregnant women in the later stages of pregnancy, but it would be helpful to get advice from public health officials on what the best approach to take. And there are 3 antibiotics that are used, all of proven equal efficacy: azithromycin, another macrolide, clarithromycin, and cotrimoxazole. Those are the antibiotics that may be used. So we're now going to have a look at pertussis across the different age groups, and we'll be bringing out the point that vaccine immunity and natural immunity wane after about 6 to 10 years. So people may be protected soon after infection or after vaccination, but that is not long lasting. And also there's a reservoir of Bordetella pertussis in the community. It's not eradicated, it's there. And although people may not be very unwell with it, they can become a source of infection for those who may be more vulnerable. So This is looking at this century so far, although it excludes 2023 so far, but this is Australia since 2000 to 2022. The columns in purple are the numbers of reported cases per year, and the line is the incidence per million. It's a bit unusual to quote per million. Usually incidence is quoted per 100,000, so there's an additional factor of 10 there. But this does show that in the early years of the century, the reported cases were relatively low and have become relatively low in the last couple of years, but with a blip in the middle, sort of between the years of 2008 and 2012. We'll discuss why that happened and what that means. Again, this is also looking at Australia. We're now looking at a shorter period. This is 2009 till 2021, and it demonstrates that blip that the notifications have decreased since the start of the last decade and until the end of this decade. Again, with that blip between 2015 and 2016. So that was looking at the whole population. Now looking at adolescents and young adults, so up to the age of 24. So this graph shows the numbers for adolescents between 15 and 19, that's the light blue color, and for older young adults, 20 to 24, over that period from 2009 to 2020. And again, what we're seeing overall, that there has been a trend, a decrease with that sort of mid-decade blip again. And why is that? That might be something we can discuss when we get to questions as to why that might have happened, what sort of phenomena might be reflected in those data. Again, we're still in Australia, and we're looking at the notification rate per 100,000 population by age and by sex. So we've got red for female and blue for male between 2013 and 2018. So it's bringing all of those cases together in that period. And what is interesting to note from here is the highest rate was in pre-teen children, the sort of the 6 to 10-year-old age group, but that all age groups are affected. So it's although we may consider that pertussis is a disease of infants, it's a disease of all ages, and in this demonstration, particularly in pre-teen children. Here's some, to put it in context, the all-age incidence of notifications in the second decade of this century was 40% less than in the first decade of this century. So we're doing something right. Rates are getting less. However, it's important that we note this, that the rates of both notification and hospitalization have been 3 to 8 times as high in Indigenous children compared to non-Indigenous children. Something which doesn't come out so much from the charts you've just looked at, but epidemics do occur every 3 to 4 years, which means we're probably due for one this year. 2/3 of cases occur in spring or summer, and that seems to be worldwide. So we're entering the season for pertussis. But here we go. Here's another one, just to bombard us with more figures. We were saying there was a decrease in the second decade of 40%, but look at this. Pertussis incidence has decreased by 500% from 2005 to 2010. So it's going in the right direction. So we're going international, so overseas, and so this is to the United States of America, and these are data for 2022. Please have a look at the table in the middle of the screen. We don't need to look at the any of the other data. So just the table in the middle of the screen. And what this is showing is that nearly a quarter of the cases of pertussis were in children aged between 1 and 6. But also nearly a half of the cases of pertussis were in people over 20. So almost half in adults. Compared to children, so perhaps pertussis should be reconsidered as being an adult's disease as well as a children's disease. These similar data from the United States of America. This is looking back now from 1990 to 2021, and is showing age group incidence per 100,000 persons. It's difficult to interpret this chart because the age groups are unequal. They're less than 1 year and 1 to 6, so we don't have the same numbers in each age group. But what we want to observe from this is that the age distribution seems to be unchanged over time, so that the lines that we can see track one another over time. So moving on now to vaccine effectiveness, we've done our bit on the sort of the epidemiology. This is looking at vaccine effectiveness in children and looking at immunity after receiving a pertussis vaccine, and noting that it does wane over time. The effectiveness can wane, down to about 50% from 2 years of when the vaccines have been administered. The pertussis vaccines that are administered or recommended for young adults and for adolescents have a reduced antigen content. So they've got the lowercase p compared to the uppercase p for the younger children. And the vaccines have been shown to be immunogenic, including in older people as well. But have also shown that immunity decreases with time, and certainly over 5 years will decrease to about 50%. What about pregnant women? Again, similar to the previous discussion with adolescents and with children. So women who are in the 3rd trimester of pregnancy who are vaccinated. This can provide transplacental transfer of pertussis antibodies to the infant, providing some protection to the newborn baby. So the efficacy has been shown, but likewise it wanes after time. And we know that women in pregnancy are recommended to be vaccinated in each pregnancy. So subsequent pregnancies to be vaccinated for pertussis as well. So moving from vaccine effectiveness to the current national immunization program schedule. Now this will differ in different jurisdictions, but this is the national schedule, and the one that we will be familiar with. And there really isn't much to say. We will be familiar with this, other than say 2 months ago, Vaxelis became an option for the vaccines at 2, 4, and 6 months in lieu of Infandrix Hexa, so of similar efficacy, but the brands are not recommended to be interchanged, so to use one or to use the other. But these are what we have: Infandrix Hexa, Infandrix IPV, the Vaxellus, Tripacil, Quadracel, Boostrix, and Adacel, and we also have Boostrix IPV and Adacel polio, which are similar. It's worth just to give a bit of historical context to this, that all of these pertussis vaccines are acellular. They were introduced in Australia in about 1997. And prior to that, the pertussis vaccines used whole cell pertussis vaccines. And whole cell pertussis vaccine is still used in many countries in the world. The whole cell pertussis vaccines were introduced to Australia in 1940, and the reason for the change to the acellular vaccine was in relation to adverse effects or potential adverse effects from the whole cell vaccine, particularly irritability and fever. But the downside of changing to the acellular vaccines is they're not as effective in terms of inducing immunity. They're not as effective as the whole cell vaccines. So moving on now from the schedule itself to the actual recommendations and the coverages. And again, there's nothing new here. Infants and children are advised to have the 5-dose schedule. The 18-month booster was reintroduced in 2016, and children under the age of 10 who've missed are advised to or recommended to follow up a catch-up schedule, and there are tools that help us to do that appropriately. So the target for that, the target has been set at 95%, and we're not doing all that badly. So this is really a very difficult chart to look at because the colors don't show very clearly. The fine faint line is the DT PA, and it may be quite difficult to see that on the chart. But essentially, these are the coverages starting from 2011 till 2020, taking quarterly data, and there's a steady increase. And although not quite at the 95% rate for DTPA, it's certainly getting in the right direction. So let's take children now at 2 years, and the same again. And we can see that not quite at the 95% mark, but getting there. So that's the coverage at 24 months, and again, same period, 2011 to 2020. And what about age 5? And at age 5, so having completed the 5-dose course, and again DTPA, you can see that as sort of the red line, and we're not quite at 95%, but we're higher than 90%, so we're on the right track, but could do better, still more to do. So let's move the age range up a little bit to the adolescents. So the optimal age for a booster for pertussis for adolescents is between 11 and 13. And again, we're looking for a coverage rate of 95%. And we're not quite there. So this chart shows the rates of coverage for adolescents in 2019, that's in blue, and 2020, that's in red. Nationally, coverage was about 86.8% in 2020, so not getting to the 95% 5% mark there. But it does seem that 2020 was consistently better than 2019 across all jurisdiction. And one might ask what happened to Tasmania in 2019, and I don't know, but it got better in 2020. So we've talked about children, adolescents. What about adults? So the Australian recommendations are that adults who want to reduce their likelihood of becoming ill with pertussis are advised and recommended to receive a pertussis-containing vaccines. And adults who need a tetanus-containing vaccine are advised to get one that also has the pertussis as well. So for adults, those are the two brands that we have, which are Adacel and Boostrix. So does that happen? Are adults getting the opportunity to get vaccinated against pertussis? Is it something that we raise in our consultations? Do we discuss that opportunistically? Do we discuss it at the time of an encounter where a vaccine is going to be given? And perhaps that's something that we should be sort of thinking about. It is probably now as good a time as any that the vaccination for pertussis in an adult is not included in the National Immunization Programme schedule or in any of the jurisdictional schedules, with the exception of pregnant women. So that means that if it's going to be given to an adult, they're going to have to pay for the vaccine and possibly for the vaccine encounter. And a tetanus, diphtheria, pertussis vaccine probably costs about $35 for a dose. So it's just that, and that may be a deterrent for some patients to get the vaccination. And moving to older persons. So what about adults over the age of 65? And the recommendation is that persons in this group should also receive a pertussis-containing vaccine if they had not received one within the previous 10 years. So and why? Well, an article by Betty Liu and colleagues had shown that although the severe morbidity from pertussis is highest in the youngest, adults can suffer serious complications, with about 10% of those aged over 65 being hospitalized with pertussis, and about 8% developing pneumonia. So it's not just a cough and a sniffle. And our final group to look at, women who are pregnant or breastfeeding. This recommendation has been jurisdictional since 2015 and has been included in the National Immunization Programme schedule since 2018. And the idea is to protect women in the later stages of their pregnancy, but also so that by passive transfer of antibodies to the fetus, they can provide some protection to the newborn during those weeks before the newborn receives their first dose of pertussis vaccine at age 6 or 8 weeks. The next group to discuss is contacts and carers, particularly thinking of childcare workers and grandparents. So these are individuals who are going to be in contact with infants under the age of 6 months, and are therefore potentially going to be vectors that could transmit pertussis to a young vulnerable infant. So household contacts and workers, healthcare workers, are recommended to be vaccinated for pertussis as well. And it would be interesting to know how many healthcare workers have received a pertussis-containing vaccine within the last 10 years, because those data are not readily, in fact, they're not available. But it would be interesting to know if healthcare workers were maintaining vaccination status for pertussis. Jumping around with our age groups a bit, we've talked about the children, the adolescents, the older people, and now we're bouncing back to the adolescents. So aiming for vaccination about between 11 and 13 years, but adolescents may miss that. They might not have been at school that day. They might have been unwell that day. So the onus then is on us as healthcare providers to fill in the gap, to ensure that adolescents do get vaccinated for pertussis, and to be opportunistic and to take chances when they occur. Okay. So what about the adults? So just to finish off, really. Recently, an increase in reported cases of pertussis in adolescents and adults has been noted in many countries, despite the high immunization rates. And it's thought that this is because adults act as a reservoir for infections in the very young, in whom pertussis may be life-threatening and severe, but also as a reservoir for infections in older people. And with increasing age, there is the phenomenon of immunosenescence. So it's the alteration of the immune system. It starts to wear out. So bones and muscles wear out, our hearts and lungs wear out, and our eyes wear out, and so does our immune system. And that lets us down and makes us more vulnerable, particularly when we have comorbidities, as cardiorespiratory diseases or diabetes in particular. So these data are from 2008 in South Australia, when there was a blip. And what this shows, if we look at the columns, which are by 10-year age groups, we actually see that more than 2/3 of notifications were in people aged 25 and older. So it's an adult's disease, or it was in 2008 in South Australia. The other point which is interesting in regard to communicability is that it is a human disease, so that we don't pass it on to other animals, and other animals don't pass it on to us. The disease called kennel cough in dogs is caused by a Bordetella genus bacteria, but that particular bacteria does not affect humans at all. So this is what we're looking at. We're looking at the waning of natural immunity and the waning of vaccine immunity as well. Suffice to say that that's what happens to our immune systems. And I think, in fact, we've got the CD8 to CD4 ratio the wrong way round, but it's essentially saying that our cells and our antibodies become less efficient with time. So we know, if we look at older people, that we do pretty well with influenza vaccine, that 8 out of 10 older people get the influenza vaccine, 6 out of 10 are getting the shingles vaccine, maybe 4 out of 10 are getting the pneumococcal vaccine, but we really don't know about what's happening with pertussis in Australia or overseas. And talking of overseas, some countries do include pertussis vaccine in their schedule for adults and older people, particularly in Italy and in the United States of America. Although I'm not sure if it's funded in the United States of America, but it's certainly in their schedule, but not as yet in Australia. And we do, I think, at our peril, we misunderestimate pertussis. We think it's a childhood disease. In adults, it may present without the classical phases, the catarrhal phase, the classic cough, whoop, and vomiting. It's difficult to detect the pathogen, and we'll just briefly show the testing that can be done. and it's difficult collecting and interpreting the data worldwide, despite great work by the World Health Organization on trying to do just that. So essentially, in the early stages of the illness, it's the PCR for the nasopharyngeal swab, and for the later stages of the illness, it's serology, IgA, which can even be used several weeks after the original infection. The natural infection produces IgA antibodies. The vaccines don't. So if a patient has IgA, it's natural infection that has caused their illness. So you can distinguish between the vaccine and between the natural illness based on the type of antibody. Okay. Okay, and essentially, we won't spend too much time looking at these, but the take-home message is the really the sort of the last point, I mean, essentially, what we're seeing is about 4 to 8 pertussis infections per 100 person years. So it's common, and some people, as we'll see with our next slide, get really sick. So this is a United States of America study looking at data from 2011 to 2015, and it found that most adults hospitalized with pertussis, 87% of them, had one or more underlying conditions, so diabetes or asthma or COPD or a cardiac disease. So it seems that you lose both ways with pertussis. If you've got a disease, a chronic disease, you're more likely to get pertussis as an older person. And if you get pertussis, you're more likely to get complications. So pertussis gets you both ways as an older person. And essentially, this are just some more data around vaccine effectiveness, to put some figures on what we were talking about a little bit earlier. And if we look at the fourth dot point in blue, this tells us that the effectiveness of the vaccines, the overall effectiveness of the vaccines, and this relates to acellular vaccine, drops to 41% at 8 or more years since last vaccination. So perhaps by recommending vaccination at 10-year intervals, perhaps we're being a little bit conservative, and it should be maybe 8 years or 5 years. Again, that's perhaps something for us to think about and discuss. Yep. So that's what happens. This is the perfect storm. As we get older, minimal antibodies, lots of disease which we don't recognize, we don't diagnose. People die, and we need a vaccine. So that's the impetus for action. And it's surveillance, monitoring, and regular vaccination, which would seem to be a good way to go. And this is just a screenshot of an article written by Michael Woodward and John Litt and Paul van Binder, really sort of looking at how can you address the issue of vaccination in older people, where there may be some resistance, or maybe apathy, but maybe negativity. And this is just, I'm not going to read through this, but it does give some tips and tricks about how we might address that with patients in our encounters. And so how else can we make a change? Well, it comes down to us as healthcare providers, whatever domains we are working in, but also it comes down to communities. So families, governments, and working together so that we can optimize, so that we can improve the vaccination rates. So clearly this applies not just to pertussis, but applies across all vaccination for Australians. So just about finished, and I think we're on time. Pertussis occurs in all age groups. It is underreported. Adults with underlying conditions are at increased risk from pertussis. Pertussis can exacerbate other disorders, asthma, COPD, and cardiac disease. Adults with underlying conditions are at risk of serious complications from pertussis, and booster vaccination may be one of the ways of helping these older people to stay healthy. I've got a list of references which will be available on the website. We won't talk through those right now. I think I'll now hand to my colleague Andrew, and we'll see if we have any questions that we can address.
Thanks very much, Andrew. That was a really comprehensive and in-depth talk on pertussis. So it's good to see that we have a number of questions. I'm going to kick one off first, just so I can get that in, just so I have prepared. I have been listening. So, you know, pre-COVID, pertussis, and you said epidemics occurred about every 3 years or so.
That's right, yes.
So pre-COVID, you know, 18 and 19, pertussis was quite high nationally.
Sure.
And then COVID came along, of
Sure.
course, that minimized everything and
Sure.
wiped it out. So should we have expected, you know, a resurge in 22, 23 with the spring summer period, which didn't occur? So should we be looking for something more significant in the 2023-24 spring summer period?
I've got a really good answer to that, Andrew. The answer is don't know. And don't know, because the phenomenon of the pandemic and social distancing, I think that sort of throws all the statistics up in the air. I don't think we can really make any definite conclusions. The trend of 3 to 4 yearly epidemics was based on the pre-pandemic phase. So, and that didn't apply from 2020 to 2022. So I don't know, and I don't know if we could perhaps take the question on notice, and we can ask some of the experts for their views on that. But the answer is I don't know. Wait and see. Watch this space.
A bit like flu, very difficult to predict.
Difficult to predict. Yeah.
A question from Louise here. And some of these questions have already been answered by you, but I will go through them. Do you measure coverage of pertussis vaccination in the over 65s? And I think you have answered that.
Oh, I think we don't. It doesn't happen. It would be great if we do. I know that some practices do it locally, so they can tell you what their rate is for their practice population, which I think is great. But it's not been done at the primary health network level, and certainly not at the Department of Health level. But I think it would be great, and it's doable because we do it with everything else. So it's doable. Yeah.
Yeah, but there's no target as such, is there?
No target as such. I think the targets are implied as many as possible.
Yeah, so it's just interesting to see one of your slides where, particularly in the elderly, you know, the coverage rates for flu is 80%,
Sure.
Shingles is 60, it drops down
Sure.
to 40 for pneumococcal. So it'd be interesting to see where pertussis
Sure.
fits,
Where it
whether or
fits
not
in,
it's
exactly.
below
Yeah.
pneumococcal or not. So
that's right.
Should we this is an anonymous question, should we keep giving pertussis vaccine every 10 years? And you have touched upon this.
I think yes and no. I think it's based on sort of the individual and their risk factors. I think certainly for childcare workers, and it's now mandated for childcare workers. For healthcare workers, it's not mandated, but I think it would make a really good idea to do that. For adults, in the absence of any evidence otherwise, yes, I think that would be appropriate to do. I'm not aware of any impetus at the moment to push that, but it would make a lot of sense.
Thank you. Is it still recommended for, this is an anonymous question, is it recommended for patients with asthma or COPD to have a pertussis vaccine every 10 years?
Yes. It's not formally, it's recommended that, I mean, the current wording is that individuals who would like to reduce their risk are recommended to have it. But I would advise anyone with asthma and COPD, and I'm sure all other, well, I can't think of a medical practitioner who would advise someone with asthma or COPD that is what they should have, yes. So really good idea.
This one's from Kath. It would be beneficial for the DTPA to be added to the doctor's bag, list of medications that
Sure.
surgeries can offer monthly.
Sure. Yeah.
Could that be considered? What do you think?
I think it's a fabulous idea. We've got this old-fashioned ADT spinning around in the fridges on doctor's bag, and based on what I've said this evening, we're not going to be giving it because we're going to be giving a pertussis-containing vaccine instead. So why isn't it in the doctor's bag? And the cost from checking recently checking an online chemist website. I won't mention any names. I know it's around about $30. So is it going to blow the health department's budget? You probably wouldn't. And in terms of the benefits of patients, not getting ill, not getting into hospital, not developing complications, I think a health economic argument would be very easy to make for that.
Here's a comment more than a question. It's anonymous. It would be good if hospital emergency departments could have Boostrix as the option rather than Adacel with treatment of tetanus-prone wounds. And I was in that situation about 4 weeks ago.
Sure. Yeah, couldn't agree more. That I think that's a really good idea. That it would be great if hospital emergency departments did just that. Great, but then you see the hospital departments are going to be, unless they pass that cost on to the patient, they're going to have to foot the bill for that extra $30. So maybe that's a deterrent or a disincentive.
This is from ISA2, if I pronounced that correctly. Apologies if I have not. Are there any contraindications of the pertussis vaccine, such as a minimal number of doses and time points to be given, and how well does it do with other vaccines in the EPI program if given around the same time?
Okay, that's a good practical question. We're talking about are there any reasons for not giving it? And the only absolute contraindication to a pertussis vaccine is anaphylaxis or severe allergy to a previous dose of a pertussis-containing vaccine, which in Australia, in fact, worldwide, you can't get pertussis vaccines without having tetanus and diphtheria antigens included as well. So it could be one or the other. But if you've had a previous allergy, particularly anaphylaxis, you don't have a dose. And the only other contraindications would be the usual contraindications for vaccination on the day. So, a child with a fever over 39, a child who's systemically unwell, we're not going to do that today. But otherwise, there are not contraindications to it. They can be given. They're compatible with other vaccines, live vaccines, and killed vaccines, and with the rotavirus vaccine as well. So there's no issue in regard to that at all. With the wholesale vaccine, there were concerns about kids who had seizure disorders, whether they should receive that or not, because it caused the children to get a high fever. But in fact, even that's been discredited. So it's not a contraindication. It's not. So it's suitable for all children and suitable for all adults. And even if you give them too frequently, that's not a problem at all. Pregnant women who've had 5 pregnancies in 5 years, well, maybe not quite that much, will have had 5 vaccines in that period of time, and there's no problem with doing that at all.
Question from the same person. Can the increase in specific pertussis antibody among the infants born to vaccinated women might interfere with the active pertussis vaccination of the infant following the primary series of vaccines? Can you understand that question?
Sorry, I completely cut out.
Okay, I'll reread it. You froze there. Can the increase in specific pertussis antibody among the infants born to vaccinated women might interfere with the active pertussis vaccination of the infant following the primary series of vaccines?
There's so fabulous question. I think that's really good. And the answer is I don't know, because I've not read anything that would indicate that that would occur. I can see what the concern would be, that you've got some passive antibodies which could mop up the acellular pertussis toxoid and the other antigens as well. So I think that's a really good question. I think the answer is likely to be no, that it doesn't. But it would be maybe we can put that on notice and to look up the answer to that, or maybe it does attenuate it to a minor degree, much less than would be of concern based on the benefits of reducing the risk of getting the a pertussis at the age of 4 or 5 months. So good question, Andrew, and I'm sort of dithering a bit on that one. I'd like to know the answer.
This one's from Amanda. How do I start this one? You mentioned Australia's due for an epidemic this year. We didn't really say that, but it's every 3 years, I guess. How can healthcare professionals prepare for this? How strong is the case to have the vaccine made available to all ages through the NIP, which it's not, unlike many other infectious diseases?
I think it's a good question, and I agree that I think we should advocate strongly to our patients, and we should advocate strongly to our lawmakers, so to the government as well. And we can do that through our lobby groups. So whether it's through our colleges, associations, I think whatever lobby groups we've got, we should be doing that. But I think that's a good response. So whether we've got an epidemic coming or not, we've still got pertussis coming, whether it's large numbers or usual numbers, and it would be we should be aiming to reduce that, minimize that, mitigate that risk, so it's at the patient level, so what we should be doing to talk to patients about getting it, but also what we should be advocating at the sort of the government level. I think it'd be a great idea to get it onto the national immunization program. If there are countries overseas that have done that. I quoted Italy, and there are others. Off the top of my head, I can't quote them. So if we could, if others can do it, why can't we?
Yes. This is from Richard. What about pertussis disease and vaccinations in immunocompromised people? What are your thoughts on that?
Yeah. Immunocompromised people are certainly at very high risk for acquiring pertussis disease from others in the community, and immunocompromised individuals are unfortunately at high risk of the complications. So there are two things there. One is the sort of the physical protection, so that keeping individuals who are at risk because of immunocompromise away from those who are known to have pertussis. So if there's been an outbreak at school or in a family, so staying away, protecting, and it's not just enough to do the mask and 1 meter. You've got to be perched in a different house to stay properly protected from pertussis. And secondly, then, is the vaccination. So individuals who are immunocompromised would certainly be strongly advised to be up to date with all vaccinations, and that should include pertussis vaccination as well. So following the schedule to adolescents, and then from then every 10 years. Should they have it any more frequently? I'm not again aware of any evidence that giving it more frequently than 10 yearly is necessary or advisable, but it could be. But certainly 10 yearly as a minimum for those people at risk. Yes, definitely.
Question from Nancy Lee. This is a nice short one. Should we go back to cellular pertussis vaccines?
Good question. It's better. It's more effective, lasts longer. But the downside is it might then become a deterrent that perhaps families would say, well, I don't want that vaccine that's going to make my child irritable and feverish and unwell for 2 days. Which is what it did. I mean, those of you in the audience tonight who are old enough and will have had kids that had the whole cell vaccine will remember those pertussis days, as I do, it's not pleasant. So I think in terms of efficacy, I think that's good, but we probably don't need to. Because we've got a more than adequate supply of the acellular, and I think perhaps it's changing the protocol. So giving it more frequently, giving it every 10 years, giving it to adults may be the way forward rather than going back to the whole cell vaccine. Again, that's my opinion. I don't believe that there's any move to bring the whole cell vaccine back.
This is from Isatur again. It's been very active with his questions. Diagnosis of pertussis is challenging because of its early symptoms overlapping with other respiratory diseases, the early stages of coughing and so forth. This is similar to the clinical diagnosis challenge of COVID-19. What can differentiate pertussis from other respiratory tract infections such as COVID?
Suspicion. That's about it, really, because it's an acute febrile respiratory illness, which is a great umbrella term for influenza, rhinovirus, adenovirus, SARS-CoV-2, everything, and they all cause very similar illnesses, and they're not necessarily consistent. So one patient may have the classical catarrhal phase and cough, whereas another may just have a bit of a cough, and maybe a bit of a cough which is typical with what you get with an adenovirus or a rhinovirus infection. So it would be fantastic if there was some way of recognizing patterns, that you could say this particular pattern of respiratory symptoms indicates pertussis or rhinovirus or RSV. Or influenza, whatever, but they don't, Andrew, and that's what makes it hard. It's not that we're incapable. We are capable, but we're dealing with something that is very variable. And so doing the PCR tests, just like we do for SARS-CoV-2, are acceptable. Acceptable, yes. I mean, I think patients are fairly used to that now, a nasal swab or a pharyngeal swab, some upper airway swab can be tested by PCR for the respiratory viruses and for pertussis. So I think probably what we should be doing in that case is thinking about more swabbing. And generally we don't. I don't know. Generally, I can't give you quote what rate of medical practitioners will or nursing practitioners would swab for a respiratory infection. I suspect it's not all that high, and perhaps it should be higher. So swabbing, I think swabbing and suspicion is probably the answer.
A question from Tony. This is an efficacious question, I guess. Would it be recommended for nurses to have the pertussis vaccine every 5 years instead of, I think the normal is 10, is that right?
It's not recommended, but it's certainly not harmful. There's a natural experiment known as pregnancy, which has shown that, because there are women who have pregnancies in fairly rapid succession, so they get their pertussis vaccine in fairly rapid succession, and they have not had any harms either for themselves or their infants as a result of that. So so the recommendations would be every 10 years. I believe that giving it every 5 years would be regarded as off-label, so that it's not in the TGA approved guidelines. It's not, in other words, not in the product information. But it probably wouldn't be harmful, but you probably wouldn't get anyone to do it for you. I think that's probably the right answer. So good idea, but 10 years.
Question, what's the time? Someone coming over from the experience in New Zealand, so it could be from a Kiwi here. They are given Boostrix in New Zealand for tetanus-prone wounds, and this is funded by the ACC.
Oh, so, fabulous! Nice. Well, let's all go to New Zealand. I think that's what we need. Yeah, great.
I'm for that. All right, so just a couple more questions. Since clinical criteria lack accuracy for diagnosis and surveillance of pertussis. Can non-outbreak settings consider shorter durations in clinical criteria?
Just trying to, could you repeat that one again? I think I know what the question is. Yeah, sure.
Since clinical criteria
Sure.
lack accuracy for diagnosis,
Yes.
surveillance of pertussis,
Yes.
can non-outbreak settings consider shorter durations in clinical criteria?
Yeah, I think you could certainly consider them, but if you've got a diagnosis of pertussis, and you can make a diagnosis of pertussis clinically, it doesn't have to be with a PCR or with serology. So I think, however pertussis has been diagnosed, whether it's clinically or on a swab or on a serology, on a blood test, if you've got the diagnosis, then the exclusion criteria need to apply. But if you haven't got a diagnosis clinically, swab or serology, then they don't apply.
Last question, and we have a few more, but we will answer these and provide them out to all those that registered next week. Any comments on blunting from receiving pertussis vaccines in a short time span?
Good question. And the answer is I don't know, and I would have to put that one on notice as well. I'm certainly, again, off the top of my head, but I've not got resources in front of me that would tell me that. I don't know, Andrew, but it's a good question, and that sort of goes back to in fact, the question but one when we're asking about having them more frequently. Does that affect the response? And it's a good question, a really good question, but I don't know.
Okay, I think we'll wrap it up there. If we can just go to the next slide. There were 29 questions, so there was a lot of questions. So for those that we didn't answer, we will get back to you and we will send them out as an email. Just thanks again, Andrew, for really giving a great talk, and really for the audience for participating in their engagement. So this was quite interactive, and this was a really nice webinar. So the evaluation form should already be in your inbox to the registered address that you registered for the webinar. If you could just spend a couple of minutes filling it out and sending it back. There's only a few questions there, so we always look for continuous improvement. The next and last webinar for 2023 is on shingles. So that's on the 15th of November, presented by our Associate Professor John Litt. And I'll have one more plug for the Primary Care Infectious Disease meeting on the 7th of October. There are a few more spots for GPs. If those spots are not taken, this is in Melbourne. If you can find the details on our website. If these spots are not taken, then they will be assigned to nurses that I know are on a waiting list. So it's 1 minute past 7. So thank you, everybody. Thanks for your participation, and see you next time. Good night.